السلام عليكم ورحمة الله وبركاته. طلاب صف الرابع نكمل محاضرات الإندوكرين سيستم. Now we will continue with parathyroid gland disorders. Few functional anatomy and physiological points. There are 4 parathyroid glands that lie behind the lobes of the thyroid, each about 25 to 40 milligram in weight. The parathyroid gland consists of 2 main functional cells. Number 1 is parafollicular cell or C cell, which secrete calcitonin. In human, calcitonin is of no clinical relevance to calcium homeostasis. While the second cell is parathyroid chief cell, which secretes parathyroid hormone in response to serum calcium. Meaning, when there is hypocalcemia or decrease in calcium level, the parathyroid gland will respond by increasing secretion of parathyroid hormone. When there is increased calcium level, the parathyroid will suppress the secretion of parathyroid hormone. Serum calcium levels are tightly regulated from moment to moment by the action of parathyroid hormones and vitamin D. So what is the action of parathyroid hormone? Parathyroid hormone acts on, number 1, renal tubules to promote the reabsorption of calcium and reduce reabsorption of phosphate, resulting in hypercalcemia and mild or low normal phosphate level. Number 2, it acts on the bone by stimulating osteoclast cell to increase bone resorption and bone formation. Number 3, it acts on the kidney to promote the conversion of vitamin D from its inactive form 25-hydroxyvitamin D to its active metabolite 1,25-dihydroxyvitamin D. And by activation of vitamin D, the following action will be obtained from vitamin D. Number 1, it also increases bone resorption. Number 2, it acts on the small intestine to increase calcium absorption from diet. Number 3, it acts on the kidney to increase excretion of calcium. More than 99% of total body calcium lie within the bone. So the main storage site for calcium is the bone. The differential diagnosis of disorder with calcium metabolism require measurement of serum calcium. Any patient we suspect there is parathyroid gland disorder, we need to measure serum calcium, serum phosphate, alkaline phosphatase, parathyroid hormone level, vitamin D level, and to assess renal function. Although the parathyroid gland detect and respond to ionized calcium only, or before that, you need to know in the blood we say there is 99% of calcium stored in the bone. So there is 1% of calcium lie within the blood. This 1% divided into 2 parts. One part is bound to proteins, mainly albumin. This is bound calcium, it is physiologically inactive. While other half is non-bound or free calcium or called ionized calcium. This is the active part of calcium. This is what parathyroid hormone or parathyroid gland detect and respond to. So, about 50% of total calcium is bound to albumin. Accordingly, if serum albumin level is reduced, so total calcium concentration will be also reduced, and it gives us a false idea about calcium level. So we need to correct calcium level according to serum albumin level. Accordingly, if serum albumin level is reduced, total calcium concentration should be corrected by adjusting the value of calcium upward by 0.8 gram for each 1 gram reduction in albumin below the normal, which is 4, according to the equation. Corrected serum calcium equal to serum calcium we measure plus 0.8 multiplied by 4 minus patient albumin. Now, presenting problem in parathyroid gland disorder, first thing we need to address parathyroid hormone excess or increasing secretion of parathyroid hormone. We say previously increased serum parathyroid level will lead to hypercalcemia and hypophosphatemia. So in order to assess patient with increased parathyroid hormone, we need to know what is hypercalcemia first. Hypercalcemia is marked by serum calcium level above the normal range, which usually more than 10.5 milligram per deciliter. Usually most patients are asymptomatic, and hypercalcemia may be noted incidentally on lab tests obtained for other reasons. We should know that hyperparathyroidism and cancer are the most two common causes for hypercalcemia. Causes of hypercalcemia can be divided into two categories. First, causes of hypercalcemia associated with elevated parathyroid level, or we call it parathyroid-related hypercalcemia. Other causes were hypercalcemia associated with low parathyroid hormone, or parathyroid non-related hypercalcemia. In the first category, the main causes are primary hyperparathyroidism, and we will discuss later, or tertiary hyperparathyroidism, drug-induced like lithium-induced hyperparathyroidism, and a rare condition, familial hypocalciuric hypercalcemia. Now, in the other categories, which is unrelated to the parathyroid glands, malignancy is the most common among this group. Could be lung, breast cancer, multiple myeloma, renal lymphoma, thyroid cancer. Next, there may be elevated level of vitamin D, like in vitamin D intoxication, or granulomatous disease like sarcoidosis or HIV, thyrotoxicosis, milk alkali syndrome, thiazide diuretic can cause hypercalcemia and suppress parathyroid hormones, steroid deficiency or adrenal insufficiency, and finally, Paget disease, but only if the patient is immobilized. How patients with hypercalcemia present? Symptoms may occur in any degree of hypercalcemia, but usually when serum calcium level exceeding 12 mg per deciliter. Patients presented with bone symptom like generalized ache and pain, renal symptom in form of polyuria, nocturia, polydipsia, renal colic, and if untreated, it can lead to acute kidney injury due to profound dehydration from polyuria and polydipsia, and increased creatine concentration, GIT or abdominal symptom in form of anorexia, nausea, vomiting sometimes, dyspepsia, constipation. So, hypercalcemia is one of the causes of constipation, peptic ulcer, and acute pancreatitis. Finally, psychiatric manifestation in form of depression, drowsiness, and impaired cognition. How we investigate patients with hypercalcemia? First to note is that when serum calcium elevation is noted in investigation, we should repeat the investigation to confirm hypercalcemia on second test. And if the second test shows hypercalcemia, it is true hypercalcemia, the next step in the diagnosis, we need to assess whether it is parathyroid related or non-parathyroid related by simultaneous measurement of serum calcium, parathyroid hormone, and phosphate level. How we treat patients with hypercalcemia in general, regardless the underlying etiology. Treatment of hypercalcemia should focus on decreasing serum calcium by increasing calcium excretion through the kidney. On the contrary, there must be a way to decrease bone resorption and intestinal absorption of calcium. If patient presented with marked mental status change, I mean disturbed level of consciousness, those presented with acute kidney injury, or if the serum calcium is more than 12, these three categories should be hospitalized and treated as inpatient. Otherwise, hypercalcemia can be treated as outpatient. So indication for hospitalization include: first, disturbed level of consciousness; 2, acute kidney injury; 3, serum calcium more than 12. The first and most important line in the management of hypercalcemia is aggressive intravenous fluid resuscitation. And once patient is volume repleted, intravenous loop diuretic should be added if serum calcium is still high. Second is intravenous bisphosphonate therapy like zoledronic acid. It is usually given for long-term control because you need to know onset of action of biphosphonate need to 48 to 72 hours to start. So it is not very useful in the first 2 days of treatment, but after start its action after 48-72 hours, it is powerful hypocalcemic agent. So we should start intravenous biphosphonate therapy as early as possible to gain its long-term benefit. Meanwhile, during the first 48 hours, calcitonin, synthetic calcitonin, can be used and act rapidly to increase calcium excretion and to reduce bone resorption, and usually combined with the fluid and diuretic therapy. In patients resistant to or cannot use biphosphonate for any cause, a monoclonal antibody called denosumab can be used. It's monoclonal antibody that prevents the action of osteoclasts and decrease bone resorption, so decrease the release of calcium from the bone. Can be used instead of biphosphonate where it is contraindicated or not tolerated. For patients who presented with serum calcium level more than 18, I mean it is very severe hypercalcemia, or those with neurological symptom or compromised kidney function, hemodialysis is indicated to quickly reduce serum calcium level. Attention should be made after we try this measure. The most important step to find the underlying etiology of hypercalcemia and direct specific therapy against that cause. Now we return to main subject, which is parathyroid gland disorder, after we know what is hypercalcemia. So, what is primary hyperparathyroidism? Primary hyperparathyroidism means increasing secretion of parathyroid gland hormones. It is the most common cause of parathyroid-mediated hypercalcemia, and the incidence highest in the 7th decade of life and is most commonly affected women. 75% occur in women. So the usual presentation is elderly women with polyuria and dehydration. Most commonly, primary hyperparathyroidism is due to parathyroid adenoma in one of the glands. However, it could be due to parathyroid gland hyperplasia, or in rare cases, parathyroid carcinoma. Usually, patients with primary hyperparathyroidism presentation usually described as bones, stones, abdominal groans, and psychic moans, which is the same sign and symptom that apply to hypercalcemia. Bone, patient presented with generalized ache and bone pain. Stones mean kidney, patient will present with polyuria, nocturia, polydipsia, frequent stone formation, and sometimes renal impairment. Abdomen, patient presented with nausea, anorexia, dyspepsia, constipation, plus minus abdominal pain from either peptic ulcer or pancreatitis, and psychic manifestation with depression is most common sign. Diagnosis of primary hyperparathyroidism is made by biochemical conformation of high serum calcium, low or lower normal phosphate level, in addition to inappropriately normal or elevated parathyroid hormones. Also, we need to collect 24-hour urine to measure urine calcium during 24 hours, which usually more than 500 milligrams per 24 hours. After biochemical confirmation of primary hyperparathyroidism, we need to localize the lesion by imaging study, and most specific imaging is systematic scan, or we can use high-definition ultrasound. Treatment of choice for primary hyperparathyroidism is parathyroidectomy, means surgery is the first-line treatment for primary hyperparathyroid. What is the indication of surgery? Is it every patient with primary hyperparathyroidism should undergo surgery? No, there is specific indication for surgery. First, younger than 50 years of age. Number 2, if there is increased serum calcium level more than 1 milligram per deciliter above the normal range, which is 10.5. Number 3, creatinine clearance below 60, meaning stage 3 or more chronic kidney disease. If patient has osteoporosis or DEXA scan below minus 2.5, and patient of preference, where the patient reluctant to frequent hospital visit and frequent surveillance. Before surgery, it's critical that an experienced surgeon perform the surgery to avoid increased risk of both of hypoparathyroidism or damaging to a vital structure like recurrent laryngeal nerve. In patients who does not meet the criteria for surgery, surveillance is recommended with annual measurement of serum calcium and creatinine level. If the primary cause of primary hyperparathyroidism is parathyroid carcinoma, we should know it is very rare, account for less than 1% of all causes of a primary hyperparathyroidism. Compare with benign primary hyperparathyroidism has equal sex distribution, more commonly presented with renal and bone manifestation, plus neck mass due to tumor enlargement. It's frequently associated with very high serum calcium level, usually more than 14 grams per deciliter, and very high parathyroid hormone level, more than 250 milligrams. Surgery is the primary and the only curative treatment. All patients with parathyroid carcinoma should be screened by genetic tests, and if genetic tests show positive screening, other family member should be screened for possible of inherited disorder. What is tertiary hyperparathyroidism? Suppose we have patients with chronic kidney disease. As you will know, majority of patients with chronic kidney disease have chronic hypocalcemia, mean low calcium level. This hypocalcemia will sense by parathyroid gland, and parathyroid gland will respond by increased secretion of parathyroid hormones. So in patients with chronic kidney disease, there is hypocalcemia that stimulates the parathyroid to secrete parathyroid hormones. If this process continues for a long time, it will result in adenoma formation in the parathyroid gland and spontaneous secretion of parathyroid without overstimulation by hypocalcemia. Instead, with time, after development of adenoma, the patient will develop hypercalcemia. So this is called tertiary hyperparathyroidism. It is most commonly seen in individuals with advanced chronic kidney disease. Because most patients with tertiary hyperparathyroidism has prolonged course of secretion of parathyroid hormone, so it have a lot of complications like severe bone loss, marked increase in or deterioration in renal function. So the majority will be indicated for surgical resection of the parathyroid glands. A new treatment called Cine-Calcet is calcimimetic drugs that enhance the sensitivity of calcium sense receptor in the parathyroid gland, so slightly decrease parathyroid gland hormone secretion, and it is licensed to use in tertiary hyperparathyroidism. Next, familial hypocalciuric hypercalcemic. It is rare. It is autosomal dominant condition. These patients are frequently asymptomatic, but in rare cases may be presented with symptom of hypercalcemia. The disease caused by mutation in calcium sense receptor means the abnormality within the parathyroid gland is which calcium level is normal. Instead, in normal person, the parathyroid gland sense calcium below or above 8.5 to 10.5. This is the normal range in which the parathyroid will act normally without increasing or decreasing parathyroid hormones. In familial hypocalciuric hypercalcemia, this normal level will shift it slightly up. So let's say from 9.5 to 11.5. Resulting in mild elevation of serum calcium level and high normal mild elevated in parathyroid level. The diagnosis is made, so before the diagnosis, we see that primary familial hypocalciuric hypercalcemia characterized by increased serum parathyroid hormone in addition to increased serum calcium. So it has picture identical to that of a primary hyperparathyroidism. How we differentiate between the two entities? By measuring 24-hour urine collection for calcium. Usually these patients have value less than 200, while primary hyperparathyroidism it is more than 500. Or by calculation of calcium creatinine clearance ratio. If it is less than 0.01, it is familial hypocalciuric. If it is more than 0.01, it is a primary hyperparathyroidism. Although it is benign condition, but the diagnosis is very important in that these patients require no intervention and should be recognized from that of a primary hyperparathyroidism to prevent unnecessary surgery. The other category of hypercalcemia, which is non-parathyroid related, most commonly malignancies. There are several mechanisms by which malignancy can cause hypercalcemia. Number one, direct mechanism, by direct metastasis to the bone and cause local osteolytic or lytic lesion. When lytic bone metastases are present, hypercalcemia results from increased mobilization of calcium from the bone. So metastasis to the bone will cause release of the calcium from the bone. This is first mechanism and the most common. Second mechanism is humoral hypercalcemia. Although it is less common, usually occur when a tumor has the ability to produce a substance or peptide called parathyroid-related peptide, which has the ability to bind to parathyroid hormone receptor and activate it. So it acts like parathyroid hormone. So it will cause rise in serum calcium level. Squamous cell cancers, breast cancers, and renal carcinoma are the most common cancer associated with hypercalcemia of malignancy. Finally, in patients with multiple myeloma, hypercalcemia is caused by release of factor or specific cytokines from the plasma cell that stimulate osteoclast activity.